morning, friends. I'm Dr. Rakesh, who's going to take up all these cases of interesting chunks echoes, especially in a population who's a diabetic. One is hypertension and obesity. Okay, good evening, friends. Let's get going. Today we are going to talk about congenital heart disease. Very interesting topic, and many of you must be interested to learn and listen about all this. This is what the journey of congenital heart disease one by one. Look, this is an engine which is almost 19 years, 40 years of an engine. When not the metallic bogies were there, they were the bogies, they were made of wood. And it used to be drawn by a very few wheels steam engines. How do we go for a congenital heart disease? This is a slide from a renowned pediatric cardiologist who talks about all these things in literature. The diagnosis of congenital heart disease represents an epitome of applied clinical knowledge. When correct inferences are drawn from accurate observations, diagnoses are made with gratifying frequencies. What does it mean by? The most important part of this slide is the chambers that do not come as labeled left atrium, left ventricular, right atrium, right ventricle. We have to identify what chamber is what is the relationship of each chamber with other chamber, and how the great arteries are originating from these ventricles. First, next important thing is in approach to congenital heart disease, we'll be looking at fetal and perinatal circulation, intracardiac pressures, then comes a sequential approach, then important consideration before starting doing an examination, classification, and whether to sedate a child or not. So all these things which make a lot of difference. When we see a person in adulthood, he has passed through from fetal to perinatal, neonatal, and finally to adolescent and adult age. So what we see in adult is established circulation, and where we presume that left ventricle is left ventricle, right ventricle is right ventricle, but this is not true in neonatal or perinatal times. We have to understand the fetal circulation for this particular purposes. Let's understand this fetal circulation. Here is a descending aorta. This descending aorta bifurcates to give two umbilical arteries apart from routine bifurcation for lower limbs. These umbilical arteries, they carry an unpurified blood or deoxygenated blood to placenta. And from placenta, this blood gets oxygenated instead of lungs. And when the blood gets oxygenated, it will go back from umbilical vein. And that's the only place in the whole of the circulation where umbilical veins or veins carry a purified blood. This is bypassed by a lever, by ductus venosus, and enters into the right atrium. Once it enters the right atrium, lot of this blood is transferred to left atrium through foramen ovale. Rest blood, I'll say 70% of the blood is transformed from right atrium to left atrium, rest 30% goes to right ventricle. Right ventricle sends a lot of blood to pulmonic artery, and since pulmonic vessels, they have not developed, this blood comes back to left atrium through ductus arteriosus. On the other hand, whatever the blood has gone into the left ventricle is being pushed into the systemic circulation, and lot of blood, majority of blood goes to the brain, and that's how the child, when is born, in soon after birth, his head has completely developed. The rest of the blood goes back into the descending aorta. So if I repeat this cycle from a descending aorta, so there's a one shunt at umbilical artery regions, second shunt at ductus venosus level, third shunt is at a foramen ovale level, and the fourth shunt is at a ductus arteriosus levels. So when the child is born, these RVRA, because LVLA, they are relatively small, these RVRA, they're relatively bigger in size because they are getting majority of blood from a IVC through this ductus venosus. And LV is not really fully developed. So is the lungs, which have not fully developed. Now the next question comes, what happens after delivery? The first circulation which is chopped off is umbilical arteries. And we have seen two umbilical cords having placenta as well as umbilical arteries. This umbilical vein through which with the ductus venosus the blood is passing through becomes atretic, and this is seen as ligament of teres in adulthood. Now the question comes, what happens to foramen ovale? If you look at this foramen ovale, it's a limbus kind of a structure where the flow is from right atrium to left atrium. And this is a kind of a valve, I say limbus or a valve, which directs a flow from right atrium to left atrium as the adult circulation grows, because once the child starts breathing, the lot of blood goes to the lungs and the flow to pulmonic vein starts, and the right atrium, left atrial pressure becomes more than right atrial pressures, and this so-called limbus comes and occupy or closes the foramen ovale. Next happens to LV. LV is getting a lot of blood. Now the blood which is going through ductus arteriosus back to pulmonic artery, that stops. And now if the ductus is present, it's going sending a blood from descending aorta to pulmonic arteries. So first it becomes ligament of teres. Second is foramen ovale, which gets closed down. Third is like ductus arteriosus, which closes down spontaneously. And fourth is all this blood is going back into the descending aorta. Let's see what is the impact of all this. Okay. Now the fetal circulation differs from adult circulation. What are the fundamental differences? In adult, we have the lungs, which is at the exchange of blood. Here in fetus, it's a placenta, which is an exchange of blood. Now, shunt, as I said, it's at placenta, foramen ovale, ductus arteriosus, ductus venosus. Now comes the fetal circulation, the cardiac chambers. Since lungs receives a very minuscule amount of blood, hence pulmonic artery, they're very small. RV is larger than LV as the child is born. RV pressure identical to left ventricle, hence ECG changes what the newborn has got a RBB kind of a pattern with which the newborn is born. So my quest of telling you all this is, when you happen to see a neonate soon after birth, you can have an RBB in ECG changes. On top of that, RVRA could be a bigger in size. And on top of that, you can hear a pulmonic murmur in the pulmonic flow because the tubes or the pulmonic arteries, they are not accustomed to high flow seen in these vessels. So what do we see in this kind of a patients? You must have heard a murmur of pulmonic flow in every neonate. And the best example which I give often is when a lot of rain happens on the rooftop and the draining pipe, it starts making a noise as the blood is rushing or gushing into that draining pipe. The same thing happens. You hear a sound, which we call as murmur in pulmonic flow, which disappears over a period of time because those pulmonic arteries, they get adjusted with large amount of flow and they relatively becomes bigger in size. Now, again repeat, primary exchange of circulation after birth is shift of blood flow from gas exchange from placenta to lungs. Interruption of umbilical cord results in increased systemic vascular resistance. resulting in a closure of very low placenta, closure of ductus venosus due to lack of flow from placenta. Lung expansion results in the following: reduction in pulmonary vascular resistance, increased pulmonic blood flow, fall in pulmonary artery pressures, functional closure of foramen ovale, and PDA closure happens due to increased arterial saturations. Now, what is the intracardiac pressures? Right atrium, right ventricle, left atrium, left ventricle. Here is the pulmonic veins. Here's the venous flow from a lower limbs. Here gives a pulmonic artery, and here goes an aorta. Normally what we have, the saturation is almost 70% in the right-sided structures. Saturation is almost 100% on the left-side structures. And there's a mean RA pressure of 3 millimeters of mercury. What we see, RV pressure is 25 millimeters of mercury. All of us understand LA pressure is 6 to 8 millimeters of mercury. And the left ventricular pressure depends. Neonate has got a blood pressure of left ventricle is only 55. As a child grows, it comes down to 65, 75, 100. So what we see a child of 2 to 3 years old or maybe 5 years old, we see a child which has got a systolic pressure of 80 to 100 millimeters of mercury. So we have to understand these pressures. In neonate, we consider RA pressure as 0, RV pressure as 25, LA pressure 5 to 8, and LV pressure as 55 millimeters of mercury. Saturation is 70 on right side and is 100 on left hand side. Let's move further. Go to a sequential approach of analyzing these chambers. What we look at the first visceral situs. What we look next, atrial situs. What we look next is atrioventricular concordance, then ventricular localization, and finally the great artery connections. So these are sequence. What do you mean by visceral situs? Visceral situs is whether my heart is lying on the left hand side of a chest or not. Atrial situs means whether the atrias are in correlation at their particular positions. Then comes the atrioventricular connection when the atrias are connected to ventricles in a proper way. And finally, what are the ventricles? What is the connection of atria to ventricle and how does the ventricles looks like? And finally, whether the right ventricle gives rise to pulmonic artery or the left ventricle gives rise to aorta. And that's all we need to understand in this sequential approach. Let's look at the visceral situs or visceroatrial situs, then atrial situs, then ventricular localization, and last is atrioventricular concordance and great artery connections. Now I'll show my slides one by one, try to make you understand, although this is more of a practical topic rather than just a pure theory. If I put my probe in the subcostal position, not parallel to, as we see in subcostal position, parallel to heart, but we do perpendicular to the heart. So if I'm putting my probe perpendicular to the heart, as here is a probe which is kept perpendicular, it cuts a section of the abdomen as if in a transverse section. So this is left, this is right, this is anterior, this is posterior. It's like a CT scan picture, what we see often when we have a CT scan. So if I put my probe like this, what will happen? I'll be able to see a left aorta on the left hand side, IVC on the right hand side, anterior would be liver, and posteriorly would be a spine. Left right side aorta, right side IVC, then anteriorly liver, and posteriorly is a spine. This is a spinal structure. Now, how do we say this is IVC? How do you say aorta? A very simple answer, the aorta could be over here also, because I've labeled, it does not mean that it is aorta only. So how do we look at that? The best answer is put a pulse wave Doppler spectrum pattern, pulse wave into the aorta, or you put a pulse wave into the so-called this structure, whatever pulsate. If this structure pulsate, this is aorta. Whatever shows respiratory variation, which is that is IVC. In normal human being, aorta is always on the left hand side, the IVC is always on the right hand side. This is fixed, nothing has ever changed in abdomen as far as your learning is concerned. Once we do this, and move the probe little anteriorly or little counterclockwise, what exactly happens? Once we see the structure as a respiratory variation structure and then moving the probe like this is perpendicular, moving the probe anteriorly, what happens? Once we move the probe anteriorly, the IVC will start opening up because this is IVC in short axis. Once we go from a short axis to a long axis, this IVC will open up, and wherever this structure, this IVC is opening up, that is morphological right atrium. Till date, it has never happened that IVC has drained into the left atrium. This is fixed. God has given in such a beautiful way that till date, it has never ever happened that IVC has opened into the left atrium. So if this is right atrium, then other structure has to be the left atrium. Is that clear? Now, if I rotate this or angulate this probe from dip or 90 degree to anteriorly and then phone almost parallel to the heart, what do I see? I see this structure. I see a structure over here, and if I show that structure a little bit, that this is once I do my complete anterior tilt so that my footprint is looking towards the right shoulder, we comes and look at this so-called a subcostal four-chamber view. In this subcostal four-chamber view, only one thing is clear, that this is right atrium. I do not know about this. I do not know about this. I do not know about this. Only fact is this is right atrium. So I'll go back to my slides previously. Here is my 100% 90-degree cross section. I opened up this cross section by tilting the probe anteriorly or footprint trying to look at my right shoulder. And thus, whenever it looks as this is becomes my right atrium. Further anterior tilt will give me this picture where this is the right atrium. And if I'm able to correlate with this right atrium to IVC, then this is right atrium, the other structure has to be left atrium. But I'll go and identify whether this is left atrium or not. And how do we identify the left atrium? Anybody will say that very easily. The left atrium has always the pulmonic venous drainage at your learning. But it could be variable because pulmonic venous drainage can happen to the left atrium or right atrium also. That is anomalous pulmonic venous drainage. But at your level, you can see a pulmonic vein over here, the upper left pulmonic vein, and here the right two lower pulmonic veins are seen. And once we switch on the colors, you find a lot of blood which is flowing from this chamber to this chamber. And if you happen to identify this pulmonic veins, obviously this becomes a left atrium. So what we have a right atrium, we have a left atrium. And once we identify these structures, now this is anterior, this is left, this is right, this is posterior. If you go back to the slide previously, I said this is anterior, this is posterior, this is left, this is right. So if I transform this slide, the same slide into this presentation, so what does it mean? This is anterior, this is left, this is right, and this is posterior. Now, if you look at this, the right ventricle and right atrium, they are anterior to left atrium and left ventricle. So the anterior and to the what? Right of the left ventricle. Is that clear? This is left side. This is right side. So they are anterior and right side of my left ventricle. And if you happen to see this kind of a picture, you should always take assured, I'm not going to go detail. We are looking at situs solitus with D loop. Are we clear till this time? Because now we have identified my IVC, we have identified my RA, we have identified my LA because of the pulmonic venous drainage. And once we have done all this, now we jolly know this is a left atrium, this is left ventricle. And if you do not see these pulmonic venous drainage, that is the one time you should start understanding something is wrong. And what could be the wrong at this moment is, you can have a wrong things in the sense the pulmonic venous drainage is not proper. Is that clear? And if this pulmonic drainage is not proper, what will happen? Normally, my right atrium and left atrium would be almost normal and same in size. Maybe the right atrium is bigger in size a little bit because the preponderance of lot of blood flow going to the right atrium and right ventricle in the fetal circulations. But if they are a little bigger in size and you can't see a pulmonic vein, and that is one point you should always understand, look, there could be an anomalous pulmonic venous drainage. Let me move further. Now, once I've seen this, so here is, you can see a pulmonic venous drainage in this patients. Here is a pulmonic veins over here. This Nyquist limit is 80. And all of you understand that pulmonic venous drainage has a flow velocity of 30 to 40 centimeters. If you can't see the pulmonic venous drainage, reduce this Nyquist limit to 40 centimeters to look at the pulmonic venous drainage. This is a site for intraatrium. So this is one of the site in subcostal view to look for atrial septal defects. Let's move further. Once we have looked all this, we go to now apical window. In apical window, we understand, we have already understood that there one chamber is possibly a morphological right atrium. This is morphological left atrium because of pulmonic vein presence. Now the question comes, what are these valves? What is this valve? This is mitral or tricuspid. Mitral or tricuspid. I do not know about this valve at all. I have to understand what is mitral valve, what is a tricuspid valve. For understanding mitral and tricuspid valve, I'm showing a comparative pictures to you. Here is four-chamber view. Here is a dilated RVRA, which is just in a newborn. Here is a pulmonic venous drainage, which is happening over here. And look at this insertion of the valve in this particular chamber, which is more apically placed as compared to this particular valve. Look, this is the insertion point of this particular valve. This is the insertion point of this particular valve. And this is this atrioventricular groove. So whatever the valve which is apically placed or towards the apical place is a tricuspid valve. Whatever the valve which is basally placed is a mitral valve. It is not always true that LA will attach to mitral valve. LA can attach to tricuspid valve also. So variability can happen in any formats. So if I have to say this tricuspid valve, this is apically placed as compared to this valve. This is a hinge point of this valve. This is a hinge point of this valve. So this is tricuspid valve and this is mitral valve. And that is how we say this is tricuspid and this is mitral valve. Is that clear? Now we go further back to my previous slide. I say this is apically placed, so this is tricuspid valve. This is basally placed. This is my mitral valve. This is LA. This is RA. This is tricuspid. This is mitral valve. Now come the question of looking at LV and RV. Very difficult issue. Well, LV is always a clean shaven structure. LV is like Dr. Jagdeep Chu, absolutely bright, clean shaven structure. And RV is like Dr. Rakesh Gupta, bearded. Lot of tuberculations and all those kinds of things would be seen in RV apex. So if I look at the structure, let me show this what is cleared or what is bearded. Here is this example where this is a clear structure. So this is Dr. Jagdeep Chuk. Jagdeep Chuk means JC versus LV. This is RV, which is RG versus RV. So bearded, lot of tuberculation in the structures. So this becomes an RV, this becomes an LV. And if this is a morphological RV, which is tuberculated a little bit over here, this is clean shaven or like no tuberculation which are present in this. We look at this LA, which is attached from a mitral valve to the LV, this atrioventricular concordance. RA to RV, atrioventricular concordance for RV. So RA is connected to tricuspid valve to RV. So there's no discrepancy. There's no discordance. Okay. Well, look at this image now over here. I'll confuse you completely over here. This is RA. This is LA. LA has got pulmonic vein seen over here. At least you can see a left pulmonic vein seen over here. Now look at this valve. This valve is apically placed as this valve is basally placed. Here is the hinge point of this valve. Here is the hinge point of this valve. So hinge point of this valve is lower side, the hinge point of this valve. So this is tricuspid valve and this is mitral valve. Correct? Now look at this LV. LV is entirely clean shaven. Jagdeep Chuk. So RA is connected to through mitral valve to LV. So this becomes atrioventricular discordance. Correct? Now on the left hand side, LA is connected from tricuspid valve to RV. Bearded. So this is atrioventricular discordance. So God has given what exactly has done. He has connected left atrium to right ventricular, left right atrium to left ventricular through corresponding valves. All right. I hope this is clear till this point. This is how we identify the structures. Now the next question comes whether my great vessels, they are connected properly or not. If you look at this short axis view, this is a plate. It is a place to keep a cup. So what we say, cup and saucer shape kind of a pattern, where you have aorta in the center, LA over here, RA over here, RVOT over here, and a pulmonic artery over here. Is a cup and saucer shape of pattern. If you happen to see, and this pulmonic artery, if it bifurcates, we are saying great artery connections are great or normal. But if you happen to see two large vessels seeing together in a same short axis view, then it's a transposition of great vessels. Very simple. If you look at one best vessel, the pulmonic artery wraps around this aorta. That's great, good connections. If you happen to see two vessels lying close to each other in a same format, then it's transposition of great vessels. Now the question, which one bifurcates? Or which one is aorta? Which one is pulmonic artery? I do not know whether this is pulmonic artery or this is aorta. This could be pulmonic artery, this could be aorta, this could be pulmonic artery, this could be aorta. I do not know about all this. What do I do then? I angulate my transducer to look at the bifurcation of these two vessels. If this artery bifurcates, this is pulmonic artery. If this artery bifurcates, this is pulmonic artery. God has never given a bifurcation to aorta at your level, because conus truncus arteriosus is one condition where the aorta gives rise to pulmonic arteries. So in this, at your level of a learning, aorta will not bifurcate, pulmonic artery will bifurcate. And if this bifurcate, this is a pulmonic artery. And that's how we look at great artery connections. All right. So this is situs solatus. We D-loop with normal great artery connections. So here we have seen aorta in the center, LA over here, interatrial septum, RA, tricuspid wall, RV, RVOT, and here is a pulmonic artery which bifurcates into two important structures. So nothing specific. Let's move further. If I have to go and repeat this slide again, I'll quickly do that. So let me just start one by one for this presentation, because this is very important. This is transection, 90-degree probe with an index marker at 3 o'clock position. Left side structure, if it's pulsatate, this is aorta. The right side structure shows respiratory variation. This is IVC. Now you angulate your transducer anteriorly so that the footprint starts looking toward right shoulder. First, we will see IVC. Angulation has to be very slow as you drive in car. Look, you never take a complete left turn of a steering. It's just a small turn of a steering will tell you, look, this is the left turn we are taking. So you have to angulate very slowly. The IVC will come up, and second structure will come up is, here is a live slide. Look, here is a slide. This shows pulsations. I can't see my IVC over here. And let's look at the next slide. It shows my L. This is IVC, which is opening into morphological L, RA. This is morphological LA because of a drainage of pulmonic veins. And this is possibly LV. This is possibly RV. This is pointing towards left hand side. This is RV, RA. They are anterior into the left of LV, LA. And this is known as normal situs. Situs solitus with D loop. Then we move to four chamber view. This is we identified as RA, as RV, RA, LA. Then we look at the insertion of these valves. The valve which is apically placed is tricuspid. The valve which is basally placed is mitral. And then we look at an LV. LV is like, remember Dr. Jagdeep Chok, clean shaven. Remember Rakesh Gupta, bearded. Lot of tribulations. And then finally, we look at the cross sections at a parasternal short axis view, cup and saucer shape of a pattern. If you happen to see, great artery connection is comfortable. Believe my words, if you have done all this, you have identified all structures, your life becomes so easy that you can easily diagnose, or you can easily say, look, this is my cup of tea or this is not my cup of tea. In our lab, I'm not joking. I'm not praising anything. We are getting lot many patients from our nearby labs. They'll take our money, start doing an echocardiography, and then after fiddling for 15-20 minutes, they say, sorry, thank you, हमारी machine नहीं ठीक काम कर रही है, आप इसका echo कहीं और करा लीजिए. What is the problem? Problem is, once they start looking at structures, they can't find what is aorta, what is pulmonic artery, and they fumble to a large extent, saying that, look, we can't do it, get it done somewhere else. So this is how we look at these vessels. Now next consideration comes, we have to identify for a cyanotic versus acyanotic lesions. Today we are going to talk about acyanotic. I'm not going to talk about cyanotic. And in this acyanotic versus cyanotic, we need to take a pulse oximeter into consideration. Don't take a Chinese pulse oximeter. Believe my words, a Chinese pulse oximeter gives you a saturation of 84 when the normal pulse saturation is 98. And this has happened many times in our lab. Once we check the pulse saturation outside with a Chinese pulse oximeter, the so-called 1,000 rupees or 800 rupees or sometime available for 500 rupees also, that absolutely nothing was visible for that. So what do? You take
one submission over here.
Pardon?
When we are doing this pediatrics, their probe is different from the adult probe.
Yes.
And the important
size
thing
of the probe is smaller.
Yes, there it is a different probe. We'll have to buy a separate probe for the kids or the infants. That is just
if you're really doing a work, you have to buy at least 3 probes. One for a neonate, just born up to 2 years of age. Then you have to buy a probe for 2 to 10 years of age. And then you have to buy a probe from 10 to 18 years of age. And if you can't buy 3, at least you have to buy 2. And what is the difference of this probe, Dr. Jagdeep Chok? The answer is the probe tip or the footprint is so small that it can insinuate in between intercostal spaces. 2, the frequency of those probes is 10 to 15 megahertz because the child does not have a depth. Third, these probes, they have a broadband frequencies because once we are doing a imaging for our neonatals, we look at higher frequency. Once we're doing a Doppler, we need to look at lower frequencies. So number of times we are imaging with higher end frequency like 10 to 15, and then we switch our probe to an adolescent or pediatric probe to look at the Doppler flows. And number of times when we looked at a jet of ASD or a VSD, with a neonatal probe, we were able to see only one jet. When we switched to the frequency to lower frequency, we were able to see multiple jets coming across ASD and VSD. So that's how many things changes. Look, at your level, you're not going to say anything like management issues and all those kind of issues. You're not going to give an exact answer. What you have to show is, look, my patient has got a congenital heart disease or not. If there is a asynotic congenital heart disease, then you have to tell whether ASD, VSD, or PD or coagulation of aorta is present or not. And once the child is cynosed, obviously you're going to say, look, this is not my bread of, this is not my cup of tea. So once you look at this child, the first important issue for this child is, look at their saturation. Their saturation would be almost normal, all four limbs. My word, very specific, almost normal, all four limbs. Two, look at this pulmonic venous blood flow. What is the difference, pulmonic venous flow? If you have an ASD, VSD, PDA, coarctation of aorta, what will happen to blood flow? Hyperemic. Lungs would be hyperemic. Child would be dyspneic, breathless, rather than less flow seen in pulmonic or aortic stenosis. Lungs not getting a flow at all. So you find underperfused lungs. So as soon as you look at a child, you look at the saturation, you look at a respiratory rate, you look at an X-ray chest, you look at an ECG, that gives you a fairly good idea, look what I'm dealing with. And as I said a couple of seconds or minutes back, respiratory rate, tachypnea, retraction of ribs, sweating while feeding, shortness of breath, child is not growing. These are all signs of increased pulmonic flow. So without an X-ray chest, without an ECG, without a pulse oximeter, without an history, you can't do a pediatric echo. Next comes what? We look at these kind of a shunts. Atrial, atrioventricular, arterial, PDA, combined ASD, VSD, PDA, no shunts, coarctation, stenotic lesions. That's what we are going to talk about today. Then next question come, whom to sedate, whom not to sedate. Whether to give sedation or no sedations. And believe my words, you need more sedation to mom and dad than a child when you're doing a pediatric echo. So this is a paper published from Journal of American Society of Echocardiography. What we follow in our lab is trichloral hydrate is commonly used in our lab. 50 milligram per kg body weight. Trichloral is a syrup which is commonly available. You give them a writing and ask the patient to buy those syrup by themselves. And if you are a treating doctor, it's good enough because the mom and dad, they want assurance. If you are not a treating physician, what we say to parents is, please ask your pediatrician whether we should give a sedation or no sedations. And believe my words, if you have done a patient a proper sedation, proper careful, the examination takes only 10 to 15 minutes. And if you have not sedated the child, you have not fed the child is not dry, parents are anxious, and I don't know what to what and all. You spend 6 to 8 hours to get a pediatric echo. So what we do in our lab is, when somebody calls for an appointment, I say when the child sleeps. Mom says 12 o'clock in the afternoon. I said no feed after 9 o'clock. Mom, the next question, my child will cry. I said, I want your child to cry. Then we ask the child to come to the lab by 11:30. The child is crying. Mom is anxious. We say, give this syrup, which you have brought along with you, according to for 50 milligram per kg body weight. Moms gives a syrup by themselves. They keep rest of them with them. And that feeds a child and both of them become comfortable in next 30 minutes time. And as soon as the child is sedated, and whatever the saturation and all those things will do much ahead of this. As soon as the child gets sedated, we immediately do an echocardiography, rest, everybody stops. We are not going to do any other patient in between. And next 15 to 20 minutes, we'll complete our study when everybody is comfortable. Next question comes, when is my child is going to become awake? I said, give him a water as much as you can because this drug will come out from urine quickly. And you know what is the impact of all these? Many parents, they give trichloryl during the night time when they want to have a fun. So let's talk of individual lesions one by one. ASD, VDSD, PDA, endocardial cushion defects, and then couple of obstructive lesions. And first of all comes atrial septal defects. What do you mean by atrial septal defects? There's a defect in interatrial septum. And what kind of these defects are present at your level? We say this is the fossa vallis. If the defect is present in the fossa vallis, we call them as secundum ASD. If the defect is present towards atrioventricular valves, this is known as primum ASD. If the defect is present towards sinus venosus or basally, we call them as septum sinus venosus ASD. But in today's circumstances, you can say that ASD, VSD, ASD is primum secundum or sinus venosus. But in true sense, we have an ASD which has got a multiple kind of an ASD, what we call them secundum, primum, then SVC and IVC type of ASD, then unroofed coronary sinus. So we have 5 type of ASD ever since we started doing a transesophageal 3 dimensions echocardiography. So what exactly happens in ASD? Where is the shunt? The shunt is between left atrium to right atrium. Where the blood will flow? Blood will flow, come from pulmonic veins, come to LA, go to LOE, and a lot of blood will migrate from LA to RA. And any one of you can get up why the blood is migrating from LA to RA. Because the LA pressures are 8, RA is 3. So a lot of blood will go to LA to RA. RA to RV, RV to pulmonic artery to pulmonic veins, and back to LA. So what happens? RA will become bigger in size, RV will become bigger in size, then pulmonic flow will increase and pulmonic venous flow will increase. And at this time, I'd like to say, if you happen to see an increased pulmonic venous flow in any patients, look, I'll go back to my slide over there. Look, the flow is not much in this patient. Oh, I'm not bothered because I don't see any hyperemic flow. If at all any shunt, which is asynotic, at least it is not ASD, VSD, PT, because if there's excessive flow, what will happen? The blood will flow from all structure will come back to pulmonic venous flow to get into the LA. And the same thing is seen in the slide. Look at this slide of mine over here, where a lot of blood is coming to this pulmonic venous flows. So look at this flow, which is a lot of blood flow is coming from. This is short axis view. I'll show you more examples. Just hold on for some time. A lot of pulmonic venous flow is coming from LA. Then this is interatrial shunt, goes to RA, and then to pulmonic artery and RV. So, okay. So this is short axis view. This is LA. This is RA. This is RV. This is RVOT. If you look at this structure, this RV and RA, they looks to be bigger as compared to LA. And RA is much bigger than LA. Normally, reverse happens. LA is small, bigger, RA is smaller. Even if it's a neonate, the size has to be almost equal. And here is much more than that. Do you see any ESD? You can say maybe because structures are dilated. And as soon as I switch on my color flow pattern, a lot of pulmonic venous flow is coming from this pulmonic veins and going into the. And that is characteristic suggestive of a ASD. And look at this ASD seen over here in the center. This is most probably secundum ASD. If you happen to see ASD over here, this is primum ASD. If you happen to see ASD lower down, this is sinus venosus. Now look at the same slide. What I said, a lot of pulmonic flow is coming over here. But can this pulmonic flow come from somewhere else also? Yes, it is possible. If you have inflammatory lung disease, even then the pulmonic flow will increase. So don't get into this factor of understanding, look, a lot of pulmonic venous blood flow is flowing. There has to be shunt. The shunt is only appreciable when RV and RA, they are bigger in size. There has to be bigger in size because this is not a pressure generated scenario. It's a volume. Lot of volume is being extra loaded on this RVRA to show you volume generated. Then what is the next scenario? If I see this way ASD, I put my sample volume or a continuous wave Doppler spectrum on a TR jet. Once I do a TR jet, what I get? A TR gradient. And in this patient have got a TR gradient of 34 millimeters of mercury. Issue is the child has got a pulmonary artery pressure of approximately 25 or 30 millimeters of mercury. Now PA pressures have started building up. Higher the PA pressures, worse is the prognosis, because whenever this PA pressure generate, it means the pulmonary artery hypertension is happening and there are chances of reversal of flow from LA to RA. It becomes RA to LA. So we have to look dilated structures. We have to look at the pulmonary artery pressures to make this scenario a little easy as far as you think. Now, I'm not going to say that you measure this ASD. If you happen to see an ASD, say thank you. Look, I've got an ASD, atrial septal defect. Refer to a pediatrician or pediatric cardiologist wherever you want to do it. Next, suppose you suspect ASD. As you suspect ASD in this patient, I can't see a flow in this. What do? I do a contrast echo in this patient. Look, there is a contrast echo for this patient. There is a suspected ASD. There's a few bubbles. No bubbles are seen over here. And you see a negative contrast or this filling defect. I'll try to hold this slide wherever it is. Now look at this is negative contrast. So there is a presence of ASD. LA pressures are much more than RA pressures. You have a contrast into it, but no contrast is coming to LA. So what do? Ask the patient to Valsalva, or what I do in my lab is जोर से चुटकी भर लो, जोर से रोएगा और जोर से जब रोएगा तो प्रेशर वल्साल्वा के जबरदस्त ऊपर चले जाएंगे. Immediately there will be a flow of bubbles from RA to LA. And that proves that this is an atrial septal defect. So there is an atrial septal defect with a negative contrast because it is not really volume overloaded the RARV. So it is a smaller intra-atrial septal defect. I'm not going to talk unroofed coronary sinuses. Let me just straightforward go to what exactly the take-home message for all this is. ASD, volume loaded conditions. Significant ASD means chamber dilatation, development of PA pressure estimated by TR jet gradient. Higher the gradient, poor is the prognosis. A little word about PFO. I'm not going to go in detail of PFO is when we look at these ASDs, we look at their size, because the next question immediately the mother, father, or attendant will ask you immediately, what is the size of my child? So we do measure the size, and what I suggest at your level to measure the size is, I can't tell you to measure in 3 dimensions echocardiography. The best part to measure the size is go to subcostal window. Let me go to subcostal window. Yeah. So here is RA, here is RV, here is LA, here is LV. Or I'll say, let me go back to my previous slide over here. So where do I measure my ASD? I'm trying to show you where do I measure my ASD. Here is in subcostal window, I'll try to measure my ASDs. If the chambers are not enlarged, definitely ASD is not bigger in size. First take home message. And let this expand completely. So whenever it expands completely, there you measure the sizes. And this could be less than 4 millimeter. You can see a small tiny hole over here. This is about 1 to 2 millimeters. So if the hole is less than 4 millimeter, that is possibly a PFO. If the hole is between 4 to 8 millimeter, is plus minus, and more than 8 millimeter is definitely an ASD. At your level, remember this. I'm not saying you remember much more than this, but at least remember all this to say that possibly is a PFO or a large ASD. 4 to 8 millimeters, we have a small ASD. Why this classification, which has been done in 2006 pediatrics and Jack in 1993, still holds true in 2021? Because what they did is they looked at all these ASD over a period of time. Less than 3 millimeter, almost 100% they closed by themselves. Then 3 to 5, almost 90% closed. 5 to 8, 80% closed. And after 8 millimeter, none of them closed. So he happened to look at an ASD, which is 4 millimeter. You say there is 80% chances or 85% chances of getting closer. Or if you look at an ASD between 4 to 8 millimeters, you should say there are chances of having about 70% closures. Play a little under. Don't be over. Because when we measure these ASD, we try to overestimate their size. So play a little under. Don't be a very cautious and always play very cautiously. So this is what I say take home messages. More than 10 millimeter in size, unlikely to close. Less than 8 millimeter size needs follow up. मैं ये कह सकता हूं इसको 6 महीने के बाद फिर दोबारा से रिपीट करने की आवश्यकता है और हो सकता है ये होल बंद हो जाए. Is that okay? Shall I move my shunt from ASD to VSD? Now look at this 4-chamber view. What is this 4-chamber view is? This is LA, this is LV, this is RA, this is RV. Now you look at two shunts over here. This is VSD shunt because this is present in ventricular septum, and here is the ASD shunt. And now, if I ask you this question, whether this ASD is present or not present, many of you will say yes, the ASD is present. Many of you will say the ASD is not present. If I have to ask this question further, I'll say my RV and RA, they are bigger in size, man. So my quest, possibly this is an ASD. Great. My RV, RA, they are bigger in size, and my LA is smaller in size. ASD could be present. But gentlemen, the most important answer is you look at this flow, which is very laminar flow. Laminar means look at the Nyquist limit. The flow velocity across this shunt is only 0.8, 0.6 based on this Nyquist limits over here. And if you don't see a color in this, which is mosaic pattern, as we see in a mosaic pattern over here, this is unlikely to be an ASD. Jab bhi, anytime we have a flow into the heart through a narrow hole, the flow velocity will increase. And can you imagine how much is the pressure between LA and RA? What could be the velocity of this shunt is? You still have a doubt. My LA pressures are 10. The RA pressures is 3 or 4 or 2, whatever it is. The gradient is only 6 to 8 millimeters of mercury. If you have to look at 8 millimeters of mercury of a gradient is, the 1 meter per second flow velocity will give you a gradient of 4 millimeters of mercury. And if you develop a gradient of 8 millimeter, the maximum flow velocity across the shunt is 1.5 meters per second. 1.5 into 1.5 is 2.25. Multiplied by 4 gives you almost 9 millimeters of mercury as a gradient across this. So if you are still in doubt, go to subcostal window, look at the flow across this by pulse wave. If the gradient, if the flow velocity is 1 to 1.5 meters per second, the flow is present, otherwise it's not. Concentrate on ventricular septal defect. What are the kind of a defect ventricular septal defect is? I'm not going to confuse you, try to make you very simple, which has been shown by this slide over here by myself. The most common VSD which is present in our day-to-day circumstances is when we look at a short axis view. Before classifying AS VSD into classes, I always look at this short axis view before classifying them at what. As the name goes for VSD, the classification which is available for VSD is innumerable. And the most commonly used classification even today is the Soto's classification, which is present from 1980 onwards. And Soto was a really great person. He's a Japanese and who made a real work easy for all of us. So how do we look at it? We look at a short axis view, and this is a place where the shunt could be between RV to LV or aorta. So first third part on the left side toward tricuspid valve is a paramembranous. Right half of our right one third is doubly committed VSD, which is associated with aortic regurg and aortic valve prolapse. And this is outlet muscular VSD. And this classification, I always owe a lot of things to Dr. Radhakrishnan back at the Scott's Hospital, Dr. Savitri Srivastav at the Scott Hospital. They're the true genius pediatric cardiologists. So this is doubly committed, which is always associated with aortic regurg and aortic valve prolapse. This center one third is outlet VSD muscular, and this proximal one third or the left side associated tricuspid valve is a paramembranous VSD. So if you look at an ASD first in this, so you doubly know what exact to correctly know what kind of a VSD I'm going to look at it. Once you look at a VSD, we come back to this classification. The same thing, same over here in this pictorial or cartoon diagram. Then you remember only two types of VSD. One is an inlet VSD, second is the outlet VSD. What do you mean by inlet VSD? Inlet means if you look at a four-chamber view, and if you can't see an aorta, you only see atrioventricular valves, mitral and tricuspid. And if you happen to look at a VSD over here, this is known as inlet VSD. If you happen to see an aorta, this becomes an outlet VSD. Once you have seen inlet VSD, once you have seen outlet VSD, then go to parasternal long axis view. And if you happen to see a parasternal long axis view, a VSD seen over here, just close to aortic valve. And this is majority of time is a paramembranous VSD. So we look at an inlet VSD, we look at an outlet VSD, we look at a paramembranous VSD, and the next classification, this paramembranous VSD is seen almost in 90% or 85% of the patients. When we look at this VSD in Plaque's window, we look at a VSD in parasternal short axis window. And if you can't look at a VSD in this place and a VSD at this place, it means you are not dealing with paramembranous VSD. The only thing left now is muscular VSD. Muscular VSD would be seen in this part of the ventricular septum. This part, this is inlet part, this is outlet part. And if you look at this next part is outlet muscular VSD. So if you look at the VSD over here, then you look at an outlet muscular VSD over here. And if you can't see a VSD over here and you see a VSD over here is inlet muscular VSD. So let me go back and show you my slide or the previous one. What kind of a VSD it is? You can't see aorta. So if you can't see an aorta over here and you see a VSD, this is inlet muscular VSD. Is that clear? I hope I'm able to make my picture as clear as possible. I'm not going to get in details of all this. What exactly happens to VSD? Well, this is a VSD between left ventricle and right ventricle. So a lot of blood will come into LA, LV, and then comes to RV and RV to pulmonic artery and back to pulmonic veins. What happened to pulmonic flow? Again increased. If you happen to see again pulmonic flow, which is increased and dilated LA and RA, which may or may not be present with VSD, because depending on a flow of a VSD or depending on the kind of a shunt across VSD, these chambers may be dilated or may not be dilated. Because this is a volume, this is not volume, this is pressure overload. LV is at a high pressure and RV is a smaller pressure as compared to this. But what will happen? The flow across mitral valve will increase, like velocity is normal up to 1.3, the velocity will become a little higher, then the velocity across pulmonic flow will also become higher, and you happen to see a lot of pulmonic venous flows. Here is an example. You see a normal LA, normal LV, aorta, and RV on top. You can't see a VSD, but as soon as I switch on my colors, you see a flow, a turbulent flow across this. And this is what outlet. This is outlet muscular VSD. And if you look at this outlet muscular VSD, we see another VSD, inlet muscular VSD. And here this is inlet muscular VSD. Here is shunt across inlet muscular VSD. And then we see in short axis view, here is the LA, here is the RV, here is the LV, here is the RV. We see a muscular VSD seen over here. So we try to prove it number of places. And then what we do? We see a shunt gradient across this muscular VSD. And how do we look at a shunt gradient? This is an example. I'm going to keep my pulse volume in this muscular VSD and switch on my pulse wave first. And if I'm Doppler spectrum able to contain them is okay. Otherwise, I'll reduce my baseline, change my baseline, or switch over to continuous wave Doppler. Next question comes. I did my Doppler. This is a continuous wave Doppler. It gives me a velocity of 2.5 meters per second. 2.5 into 2.5 into 4. What's the gradient? Only 34. 2.5 into 2.5, 6.25 into 4, 35 millimeters of a gradient. So what is the problem? Is this a good VSD or this is a bad VSD? If I gradient is low, then I'm really concerned. But at the same time, I should be concerned because it depends on what kind of an age I'm looking at a VSD. If I'm looking at a VSD of a neonate, where I expect my LV pressure to be 50 millimeters of mercury, where my RV pressure is about 15 or 20 millimeters of mercury, the gradient is only 30 millimeters. If I happen to see a gradient of 30 millimeters with 55 millimeters of LV pressures, and how do you see LV pressure? By looking at the blood pressure. Blood pressure is same as LV pressure in the absence of any aortic stenosis. So if I look at my pressure, this is 55 of LV, and I look at a gradient of 35, so what becomes the RV pressure? Only 20. I'm not bothered. But at the same case, if I look at an adult patient of whose blood pressure is 110 millimeters of mercury, and the RV pressure is 25 in that patient, 110 minus 25, what should be the gradient? It should be almost 85 millimeters of mercury. If I happen to see a gradient of only 85 millimeters of mercury, oh my God, this patient has got a raised pulmonary artery pressure. So this shunts tell you about the gradient across LV-RV. If the gradients are less, it means the RV pressures have built up. And if the RV pressures are built up, it means the patient has gone to pulmonary artery hypertension. Can you check up this RV pressure in other way? Yes. We put a sample volume across this tricuspid valve. Look at the TR gradients. Add RA pressure to it. That'll give you pulmonary artery pressure. Whatever the TR gradient is, that is RV systolic pressure. If RV systolic pressure is 55, this gradient is 35. 55 plus 35 will become how much? 90 millimeters of mercury. So LV pressure is 100 and we're getting a 90 millimeter. You go back to this gradient or you look at this gradient again, because there cannot be a difference of 10 millimeter. There could be a difference of 1 to 2 millimeter, but not 10 millimeter. Only thing what happens is either we have not correctly estimated by pulmonary artery pressures, or we have not correctly, or we are not aligned to these jets of VSD. Once we have done this, what do we do next? Here is example. Look at this VSD, which is paramembranous VSD. And if I switch on my colors, look carefully, the blood is flowing between LV to RV and RV to LV. This blue color is seen intermittently over this. I'll try to stop this blue color. Here, look, the blue color is coming in this space. So this is bidirectional shunt. And look, this is paramembranous VSD. This is paramembranous VSD. Paramembranous VSD, and this paramembranous VSD is also seen in short axis view as paramembranous VSD, but the flow has become bidirectional. We do not measure VSD majority of times. Some people they do measure, some people they do not measure, but at least I don't measure my VSD because I look at the gradients, how much is the gradient between. So if you have a small VSD in presence of a large VSD, multiple VSDs are present. So you reduce the CFM scale to see a smaller VSD. Then once we look at a VSD, then we have to say them what kind of this VSD, do they need closer or no closer, as we talked in ASD. Before I go, many of you must have read this Garbaudet syndrome. What is this Garbaudet is? You know, like Harrison wrote a big medicine book. Huss wrote a book, big cardiology book, and they all went away, leaving the books behind them to read for us. So same is Garbaudet designed another VSD, where this VSD, which opens from LV to, not to RV, it opens in between atrioventricular groove. This is a tricuspid valve insertion. This is mitral valve insertion. So bloody this VSD goes from this hole and comes into RA, which is very peculiar. And this peculiar VSD, if I show my dynamic picture, this is my LA, this is my LY, this is my RA, this is my RV. So this VSD, it goes not from this hole, it goes from this hole. Here is tricuspid valve, here is this mitral valve, and this bloody VSD goes from this here to LV2. And this is classically known as atrioventricular groove, from which this VSD presents, and this is known as Garbaudet syndrome. What? Restrictive versus non-restrictive VSD. Take home messages: pressure dependent lesion, chamber dilatation in RV, LVLA. Size does not make a difference. It's a site or pressure will make a difference. Now the word is restrictive versus non-restrictive VSD. I can quote an example of my patient. She lived for the age of 66 years and delivered about 11 child. And she had a perimembranous restrictive VSD. No issues. What is restrictive is when the VSD is generating so much of a pressure that is very small in size. The gradient across the VSD is 100. If I go back to my previous slide and show you what do you mean by 100 millimeters of gradients is, look at this slide over here. My LV is 110 millimeters of mercury and the gradient across this is 95 or 100 millimeters of mercury. I put my sample volume over here and this sample volume gives me a gradient of almost 4.5, 4.6 meters per second. It means that if the systolic blood pressure is 110 and the gradient is 100 millimeters of mercury, what would be the RV pressure? Only 10 millimeters of mercury. When the hole is small, gradient is high, we call them as restrictive VSD. When the hole is larger and the gradient is smaller, we call them as non-restrictive VSDs. This is a non-restrictive VSD. If you put a sample volume here, the gradient would be only 10 millimeters of mercury. What does it mean by? My LV pressure is 110, my RV pressure is 100 millimeters of mercury, the gradient is only 10 millimeters of mercury. So this becomes non-restrictive VSD and that becomes restrictive VSD. And majority of restrictive VSD that do not need any closure unless until we want to close them for our personal gains. And that is very, very important. The patient I was talking about, she was having a perimembranous restrictive VSD. And whenever I used to look at this restrictive VSD, the best clinical sign is if you put a chest stethoscope on their chest, very high murmur, high frequency murmur you can hear. Just put a stent. Anywhere in the chest you put a stent, you will find that sound seen or heard all over the chest. So you look at this ASD, VSD, the only thing is if the VSD is small, high gradient is restrictive. If it's not small, small gradient, large VSD with the small gradient, we call them as non-restrictive. So what do? We look at the hemodynamics. Echo can only make the pressure difference between the chambers. What cannot measure the exact pressure of the chamber in other ways. Then we look at between the chambers, systolic and diastolic, and the direction of blood flow. At your level, I'm going to stick at this point because I'm not going to talk more on this particular phenomena. Large versus small or moderate, when to close, when not to close, that's not your parameter. But only one thing I'd like to say at this moment is these VSDs, the size becomes smaller if the child growth happens. What does it mean by? If I happen to measure the size of the VSD as 8 millimeter today, if the growth of a child is under nutrition, become better nutrition is being done to the child. With the growth, the size becomes smaller. And that's what exactly happens with this kind of an VSDs. Let's see patent ductus arteriosus. Now again, my cartoon. I moved I started with the shunt over here. I moved to the shunt over here. Now I've gone through all these shunt. Now my shunt is between aorta and pulmonic artery. Lot of flow into the pulmonic artery, pulmonic veins, back to LA, back to LV, and then to aorta. So what will happen? LV, LA will become bigger or may not become bigger. But you have a lot of pulmonic venous flow, so is the mitral flow, so is the aortic flow, and then you see a pulmonic flow velocity, which is normal because we know flow is happening to this, and a lot of pulmonic venous flow is seen in this. Where do we see in PDA? We always see a PDA in parasternal short axis view. This is parasternal short axis view. We look at an LA, we look at an LV, we look at an RV, we look at an RVOT. Here is a pulmonic valves. Pulmonic artery bifurcates, right goes like this, left goes like this to the descending aorta. And the PDA is from descending aorta to left pulmonic artery. So what we see a pulmonic artery flow going back from descending aorta to pulmonic artery. Why? Because the pressure of the left ventricle or the aorta is much more than pulmonic artery. If my LV pressure is 100 millimeters of mercury, the pulmonic pressure is only 25 millimeters of mercury. This is a gradient of almost 75, which transport into almost 4.2 millimeters of flow velocities. So we put a sample volume and we cannot see a better flow like this. This is almost a ductal, or we say like, I forgot the name I'm going to say. This is almost a fetal ductal flow, large flow, which is in fetus, it happens from pulmonic artery to descending aorta. The reversal happen, that's why we can say patent ductus arteriosus. And that's all you need to understand, that if you look at the flow, put a Doppler spectrum pattern across this and you get a. So this is how we look at PDA. And once you look at the PDA, then we look at various other things for PDA. I'm not going to talk of all those kind of a thing at this moment. You have to identify this patent ductus. Let's see example 1 or 2 for both coarctation of aorta. Where do look for a coarctation of aorta? We look for a coarctation of aorta in the suprasternal notch. Here is aorta, here is a pulmonic artery, here is aorta. Aorta gives rise to innominate artery, left carotid, left subclavian over here, and here is a descending aorta, here is a ductus. So you see a coarctation of aorta just distal to left pulmonic, left subclavian artery, and you see a turbulence flow over here. Now the flow is laminar. We see a turbulence. This is a mirror eye image. So the ductus flow is seen over here, and we look at a gradient at proximal to ductus by pulse wave as we do in LVOT, then switch over to continuous wave Doppler, and now you can see both the flows together. This is proximal to ductus and this is peak ductus. So this is more than 3 millimeters of mercury, though we have seen only 36, but it's almost 40-45 millimeters of mercury. So this is 1 meters of a flow that correspond to 4 millimeters of mercury. This is almost 3.5, which correspond to almost 45 millimeters of mercury. And what is the gradient across this ductus is 30, 40, if this is 40 millimeters, minus 4 would be the 36 millimeter of a gradient across the temples. Peak gradient by pulse wave, 4 millimeter. Peak gradient across 36. Suppose it's 36. The coactation of aorta gradient is 32 millimeters of mercury. Anything more than 20 millimeters is considered as significant. What do you do with coactation of aorta? If it's in a newborn, where majority of time is being found because the child comes with LV hypertrophy or with little higher blood pressures, they need a surgery. Time bound, they can dilate it, but they need a surgery because dilatation, the stenosis happen very fast. If the same thing is seen in adulthood, we do a stenting with the self-expanding stents. I'm not going to talk of all this. This is pictorial diagram done by me in adult form versus infantile forms. We are not going to talk about this all details. So this is only answer is once we see distal to this is adult form of coactation of aorta. Bicuspid valve, variety of these bicuspid valves are often seen, especially the aortic, and many of you must have seen the aortic bicuspid valve. Live example is here when we see a doming of these aortic valve leaflets. When we see doming of this aortic valve leaflet, we go in short axis view. I'll try to freeze this frame for you. One valve is opening like this, the other valve is opening like this, and we do not see the third valve opening. This is known as the bicuspid aortic valve. And whenever there is a bicuspid aortic valve, what will happen? The flow velocity across the aortic valve will increase. So we look at a bicuspid valve like this. Nothing to talk about all this at your level. We look at a pulmonic stenosis. Pulmonic stenosis would be at the level of pulmonic valves. It would distal to pulmonic valves, below the pulmonic valves in the peripheral pulmonic arteries. If you happen to look at this is a pulmonic valve and you see a turbulence out here. So this is valvular pulmonic stenosis. If you happen to see a turbulence over here, this is subpulmonic. If you happen to see a pulmonic stenosis, turbulence distal to pulmonic valve, that is suprapulmonic valvular stenosis. And majority of these valvular stenosis, they come by associated with some lesion. This is very rare to have isolated pulmonic stenosis, but they do happen. Recently, we recorded one with isolated pulmonic stenosis. When this pulmonic stenosis is seen in peripheral arteries, like look at the turbulence over here, look at the turbulence over here. This is known as peripheral pulmonic artery stenosis. If you happen to see this kind of a picture in neonates, very well accepted, as I said in the beginning of my talk, the lungs are exposed to large amount of blood flow. The pulmonic arteries are not tuned to that kind of a blood flow. The size is small. As the age advances, more and more blood is flowing to them and the pulmonic arteries, these turbulence disappears. But the valvular will not disappear because valvular stenosis is at the level of pulmonic valve because the valve has to be thickened. Supravalvular and subpulmonic valvular pulmonic stenosis. Subvalvular means below the valves. Distal to valve is supravalvular because some kind of a membrane which is present in this subvalvular versus supravalvular. So this is what you need to look at as asynotic congenital heart disease. We'll show many more examples of other things, a rare one to talk about this asynotic congenital heart disease subsequently. So I'll put my presentation stop over here and stop my